So hello dear students, welcome back to this rapid revision class on National Health Program. So whatever I've taught you in the main lectures, I've summed it up in this rapid revision video with some of the updates as well, okay? So let us start with the first one. Yes, so what is this? You all know this is National TB Elimination Program. This was the older logo, guys, okay? This was the older logo of RNTCP, Revised National TB Control Program. And in 2020, okay, it became what? National TB Elimination Program. So this is the current logo, okay? This is the current logo. All right, how can you identify it? It's very easy. There's a lung made over here. TB harega, desh jeetega. So that's very important, okay? National TB Elimination Program. Now, National TB Elimination Program wants to end TB by 2025. We have also learned in the main videos that India wants to eliminate, if anybody asks you, HIV by 2024, TB everybody by 2025, and malaria, okay? India wants to eliminate malaria by 2030. Read it together, all these three, okay? In this program, we want to achieve mortality reduction by 90% and incidence reduction by 80%. That means new cases reduction by 80%. Now, under this NTP, National TB Elimination Program, there is a national strategic plan for TB elimination, okay, which was 2017 to till 2025. Yeah, so launch date 2017 to 2025. And what is the vision? The vision is TB free India, okay? The vision is TB free India. In fact, it is because of TB, there should be zero death, zero disease, as well as zero poverty. Eliminate TB by 2025, 5 years ahead of SDG. And what is the strategy for TB elimination over here? So please remember, first we need to detect people who are suffering from TB. Detect, treat them, prevent, build, okay? Now this is very important. Detect, because you know, if a case of TB is not treated, okay, then the case of TB has the potential to affect 10 to 15 persons in a year. So therefore we were first focusing on detection, treating, preventing and building. All right, so that is very, very important. Now, according to the latest TB annual reports, TB incidence in India, maybe you can be asked, 188 per lakh population. MDR TB is 4 per lakh. XDR is what is the full form? Extensive drug resistance. Please don't say extremely drug resistant TB. No, extensive drug resistant TB. Sometimes they definitely ask you the full form, guys, okay? TB death is 37 per lakh population. So again, this is for your information, but it is important, okay? Now, what are the main strategies under this program that have been adopted, okay? So now we focus on TB case detection. Why have I put this point? Because they ask you, do you have active TB case detection? Yes. So in the TB program, we rely on active TB case finding, okay, among high-risk populations, as well as there is an intensified case finding and passive case finding. Now see, one other point I want to stress over here, most national health programs in India, okay, they rely on which level of prevention? So the most national health programs in India rely on secondary level of prevention, okay? Remember this, most national health programs in India rely on secondary level. Of course, for NCDs, the best level of prevention is, although secondary level of prevention is being done for NCDs also, but for NCDs, the best level of prevention, everybody, is what? Primordial. Primordial over here means I don't want you to start smoking and drinking, right? But over here, the best is early diagnosis. Now for leprosy also, we are trying to make house to house visit to diagnose cases of leprosy early, okay? Malaria also, multipurpose worker male visits every house fortnightly, okay, to detect cases of malaria. Similarly in TB, okay? And anybody who's helping in TB case detection is going to get an incentive of rupees 500, okay? Anybody who helps, even a member of the society, okay, including member of society, even if it's a member of society, anybody who's helping us detect the case of TB will get an incentive of rupees 500. Intensified case finding is provider initiated TB case finding for patients attending health facilities with comorbidities, like people who are suffering from diabetes, okay, they can go on to develop TB. So them we are screening for diabetes also. We are taking that opportunity. that he's presenting with other comorbidities and we are screening him for TB. Passive case finding is from TB clinic. Like every health facility has to report the number of TB cases that it receives every month. Okay. Then this is very important, certain incentives which are released under the program. Nikshay Poshan Yojana is nothing but rupees 500 per month. Nutritional incentive, okay, to all notified TB patients. This is given to all notified TB patients. And in tribal or hilly areas, okay, in tribal or hilly areas, guys, this nutritional incentive is how much? This nutritional incentive is rupees 750 per month, okay. Then incentive to treatment providers. Now what do I mean by treatment providers? Please remember, it is rupees 1000 for both new and previously treated cases. Here I'll write it. So for treatment providers, how much is the incentive? Rupees 1000, okay, for both new and previously treated TB patients, okay. And for MDR, XDR, how much it is? MDR and XDR, how much it is? Rupees 5000, okay. 5000 में rupees 2000 at the end of IP phase and rupees 3000 at the end of CP phase. Like anybody who's acting as a DOTS provider. Asha workers can also act as a DOTS provider. Except for the patient's own parents, anybody can act as a DOTS provider. Okay? What about private practitioners, guys? So we have studied in the main video also private practitioners. Okay, now private practitioners are going to get at the time of notification, okay, when they notify a case of TB, like I'm a private practitioner, case of TB comes to me for checkup, at the time of notification, so notification of TB rupees 500, okay, and again on treatment completion, okay, again on treatment completion when they this thing, okay, again on treatment completion rupees 500. So private practitioner altogether, guys, is getting rupees 1000, and this has to be done, okay. Notification of a case of TB received by a private practitioner should be done within 30 days. Please remember, within 30 days of receiving the case, the person should notify, the private practitioner should notify. TB Mukt Bharat, you will see a new initiative has also come, TB Mukt Bharat, in which monthly food baskets are given to patients. So this is very, very important incentive slide. Okay, private practitioner has to notify a case of TB within 30 days of reporting. He'll get rupees 500, and again when he notifies when the treatment is complete, he'll again get rupees 500. So total incentive to a private practitioner is 1000. Okay. Another, what is this? Joint effort for elimination of TB. So please remember, this is JEET strategy, okay. In this we want to increase the basically notification rate, targeting by to increase the notification rate by private practitioners. Now it says joint efforts, okay. Joint effort means whose effort? So it is both international and national. Like international organizations are also helping out, and national, of course, state, district TB, all those central TB division, everybody. Okay, so we want to reduce incidence prevalence, but you know, one of the most important reason why TB cannot be eliminated so far is non-compliance, okay, non-notification rate by the private practitioners. They do their own regimen, okay, which the patient might not follow or continue. So JEET strategy mein we are trying to increase notification rate by private practitioners. There are certain softwares for TB notification. This is important. This is known as Nikshay. Okay, Nikshay is what? Technology-based surveillance for TB patients. Okay, this is technology, IT-based or technology-based surveillance for what? Technology-based surveillance for TB patients. Okay, the image is very important. I'll show you the image. Here only I would like to make you remember about two more things. Nikusht and Nishchay. What were they, guys? Nikusht and Nishchay. Now, Nikusht is Nikusht, okay, rogue free. So that is technology based surveillance for which patients? Leprosy patients. And And nishchay means make up your mind. So when a woman gets pregnant, she should make up her mind whether she wants the baby or not. That's how you can remember. So nishchay is free, home-based UPT testing kits, okay, testing kits provided to rural area women, slum dwellers, okay, provided free by ASHA workers, okay. So that is what is nishchay. Okay. All right. Then there are few softwares to ensure TB treatment compliance and surveillance. One is DOTS 99, again important image, and MUM. Okay, medication event reminder modulator. Now this is GPS linked, okay. It's being tracked by GPS. So when a patient takes the medicine, the authorities come to know that yes, he has taken the medicine. This is the logo for nishchay, okay, technology based surveillance for TB patient. This is the logo for DOTS 99. Now what does 99 means? By means of this, see here you can say this toll free number. So whenever you take a medicine, you have to call on this toll free number. So this is going to ensure, by this we want to achieve 90% cure rate for TB. Okay, by this initiative, we want to achieve 90% cure rate, 99% cure rate for TB. And this is a MUM, medication event reminder modulator. Okay, this is what a MUM box. Okay, now this is GPS linked. All right, and this tells us when a person takes his medicines or not. Okay, so MUM. So these are certain schemes. Okay, other things that you have to know from TB elimination program revise as per the updates also are a few definitions, guys. Okay, definitions like what is monodrug resistant TB? Resistant to any first line anti-TB drug other than rifampicin, because if the person is only resistant to rifampicin, he will be treated as a rifampicin resistant TB. Therefore, other than rifampicin, if a person is resistant to any first line anti-TB drug, monoresistant. Now suppose he is resistant to only isoniazid, he'll be called as isoniazid monoresistant. What is polydrug resistant? Resistant to poly means two or more than two first line drugs other than rifampicin and isoniazid, because if the person is resistant to particularly isoniazid and rifampicin, he'll be called as a MDR TB. Okay? So rifampicin resistant means resistant to rifampicin alone, okay, with or without resistance to other first line anti-TB drug. If he is rifampicin and isoniazid, MDR. If he is resistant to rifampicin and any other first line anti-TB drug, he'll be called as rifampicin resistant only. And any person who is rifampicin resistant is treated as MDR only. Okay? All these definitions are important. MDR we all know is resistant to rifampicin and isoniazid. Okay, what is pre-XDR? Now there's a term which is also called as pre-XDR. Pre-XDR means resistant to INH and rifampicin, means MDR, plus any fluoroquinolone except levo or moxi. Because if a person is resistant to levo or froxy, okay, group A drugs, वो XDR हो जाता है. See, XDR, resistant to isoniazid rifampicin, meaning MDR, plus any fluoroquinolone, plus group A drugs. In group A drugs, particularly the person is resistant to either levo, moxi, linezolid, bedaquiline or delaminate. Okay, these are the group A drugs. That will be called as XDR resistant. Okay, see once again. Monodrug resistant, resistant to only one first line anti-TB drug other than rifampicin. If that monoresistant, it is to isoniazid, isoniazid. Polydrug, both isoniazid, like two or more drugs, okay, resistant to two or more first line drugs other than rifampicin and isoniazid. Because if it is rifampicin and isoniazid, it is MDR TB. Okay, all right. What is pre-XDR? MDR plus any fluoroquinolone except moxi and levo. And XDR is MDR plus fluoroquinolone plus any group A drug. Group A drug can include levo, moxi, linezolid, bedaquiline. Okay? So this is very, very important, the definitions of drug resistant TB. Okay, let us look at some other definitions also which could come in your exams, like who is a TB cured person. Okay, so TB person who has completed treatment and has a negative sputum test report, like he has completed treatment for the entire duration what he was supposed to take, and he has a TB report which is negative. Whose TB complete, only treatment complete, person who has completed treatment but no documented negative sputum test report, or sputum test report is not available, like he's completed his treatment but he does not have a negative TB report. Okay, so that is important. TB treatment failure means treatment after failure. After previous sputum negative report, person is sputum positive anytime or sputum positive even at 5th month. So if the person turns out to be sputum positive at 5th month, okay, or once the report was done was TB negative, treatment sputum negative, now again is sputum positive. Okay, so any time during his treatment the person's sputum negative report has turned into sputum positive. Laws to follow up, we all know, interruption of treatment for more than 1 month. Okay, please remember when I say new case of TB, new case means the person who's been identified as TB positive for the first time, means first time taking treatment. Okay, you can say it is new cases, first time taking TB treatment. Okay, we can say that also, or we can also say, okay, has taken TB treatment for less than 1 month duration. Okay, if any person who has taken TB treatment, all right, for more than 1 month duration, guys, TB treatment for more than 1 month duration will be treated as a what? Previously treated TB case. Okay, will be treated as a previously treated, will be treated as a, taken as a previously treated TB case. And in previously treated TB case, one of the very important thing is recurrent TB. Patient is sputum positive anytime after completing TB treatment. Like nowadays, we don't use the word defaulters and relapse. Okay, the person completed the TB treatment, okay, has been declared cured or is taken the entire treatment, but now is again sputum positive. Okay, so this is very important. Laws to follow up means that the person was taking treatment, has taken at least for 1 month and now has disappeared. Okay, so these are very important terms that can come in your exams. Next, of course, diagnostic modalities under NTEP is what is the screening test of first investigation of choice. Still we have sputum microscopy. You cannot say that sputum microscopy is not done. The first investigation of choice is sputum microscopy. If I present with cough for more than 2 weeks, I have to get a sputum microscopy done. Obviously, CB-NAT has now become universalized, means anybody who's presenting with cough for more than 2 weeks duration will get a CB-NAT also done. But prior to that, you have to do a sputum testing also. And if sputum comes out negative, please repeat sputum once again alongside doing CB-NAT. Okay, so screening test of first investigation of choice is sputum microscopy. Okay, it has low sensitivity, but just because India is a TB endemic area country, we cannot use any other test as a screening modality. First, we have to go for a sputum microscopy. Confirmatory test is CB-NAT. Okay, has high sensitivity and high specificity. And please remember, CB-NAT has now become universalized. So universalization of CB-NAT has now been done. Okay, any person who presents with cough for more than 2 weeks duration will have to undergo CB-NAT. CB-NAT detects resistance to only rifampicin. Please don't say it's the gold standard. Gold standard still is liquid culture. Okay, and when we want to detect the resistance to both rifampicin and isoniazid, we're going to do a line probe assay. Okay. Now, treatment modalities में DSTB means drug sensitive TB. So we all know that in this now, whether it is new and previously treated, okay, you remember previously treated has taken treatment for more than 1 month duration. In this, mostly we are having recurrent TB cases. So both new and previously treated TB patients, we are going to give, if the person is if drugs are acting on him, a case of drug sensitive TB, 6 months duration, okay, 2 HRZE and 4 HRE. Okay, if the person is isoniazid monoresistant, okay, only resistant to isoniazid, 6-0, 0 over here means 6 months of pyrazinamide, ethambutol, rifampicin and O से levofloxacin. ठीक है, so H monoresistant TB is only 60. ठीक है, so 6 months of all these 4 drugs. Okay, that's how you can remember from 0. All right, then MDR TB में, now if a person is MDR TB, nowadays we don't rely on any injectables. All oral drugs are being given. So all oral shorter bedaquiline regimen in case of MDR TB, 4 to 6 months of Zeat-Chop and 5 months of Zeop. What was this if you remember? Z is pyrazinamide, ethambutol, ET is ethionamide, clofazimine, okay, high dose isoniazid, levofloxacin and bedaquiline. ठीक है, so MDR TB all oral shorter drug regimen if we are giving, it is total duration is 9 to 11 months. This is a PYQ. Okay, 4 to 6 months if you have to divide it, 4 to 6 months of Zeat-Chop and 5 months of Zeop. ठीक है, and if the person is XDR TB, okay, then all oral longer bedaquiline regimen, which is 18 to 20 months. So you can see all oral regimens are used. This is actually bedaquiline C2L2. That means we are giving bedaquiline, clofazimine, cycloserine, levofloxacin and linezolid. Okay, there's also BPAL regimen for XDR TB, but that's under trial. Okay, WHO has started it, but in India, BPAL regimen is under trial. See, it is under trial for all eligible people diagnosed with MDR, RR, rifampicin resistant TB. Recommendation includes a shorter 6-month regimen also comprising bedaquiline. Okay, BPAL is what? Bedaquiline, pretomanid, linezolid and moxifloxacin. Okay, so this is very, very important, but then it is under trial. Okay, now the most important thing that I want you to remember is where would you do shorter oral bedaquiline regimen? We said MDR. Okay, so here even if the person is rifampicin resistant alone will be treated as a case of MDR, so there you can give, or if the person is rifampicin resistant but isoniazid resistant but only to one gene, either INHA or CATG mutation. So that we do by doing a line probe assay. You will put the person on shorter oral bedaquiline regimen, which is 9 to 11 months, 4 to 6 months of Zeat-Chop and 5 months of Zeop. Okay, but all oral longer bedaquiline regimen of 18 to 20 months, you're going to put the people who are suffering from XDR, and even if the person is MDR, okay, but isoniazid resistant to both the genes, both INHA and CATG, then we are going to go for all oral longer bedaquiline regimen. You need to know this, okay, that is important. Bedaquiline, B2, C2 and L2. Okay, now this is a new initiative which has come under the program. This is TB Mukt Bharat, guys. Under this, please don't say this is the logo of TB. This is a new initiative. What is TB Mukt Bharat? So there is Pradhan Mantri TB Mukt Bharat Abhiyan. It is an initiative of Ministry of Health and Family Welfare, which is progressing. It is an initiative to progress country's elimination towards TB by 2025. Okay, here we are going to see TB Mukt Bharat ke liye, we are going to provide additional support to improve treatment outcomes, augment community involvement, okay, let the people get involved, and CSR activities, corporate social responsibility. So basically we have come up with the concept of Nikshay Mitra. This can come as an MCQ, okay. It is to ensure additional diagnostic, nutritional and vocational support to those on TB treatment. Okay, who are Nikshay Mitras? They are donors who can support by adopting a health facility or an individual donor, block, urbans, wards, district for accelerating response against TB. Okay, so basically guys, who can be an Nikshay Mitra? We are offering additional support to TB patients, okay, additional support. So under corporate social responsibilities, like corporates, they can adopt TB patients. So Nikshay Mitras can be individuals, NGOs, political parties, corporates, institutions, elected representatives. They can support TB patients from a period of 6 months up to 3 years. So you can get that Nikshay Mitras can support up to 1 year, 2 year, 3 years, okay, for their nutritional requirements and medicine. So in this, you remember under TB Mukt Bharat, nutritional baskets are being given every month. Okay, so these Nikshay Mitras can provide nutritional support as well as treatment support. Okay? Okay, so moving ahead, organizational setup under the program, you have to remember one TB unit, like you have a central TB division, state TB division, district TB division, then we have TB units, right? One TB unit. So TB unit is nothing but tuberculosis unit, okay? And one TB unit, everybody is pricing for 1 to 2 lakh population, which is meant for TB diagnostics also, treatment also, lab supervisors. And most peripheral are DMCs. What were DMC? Designated microscopy centers, okay? This is what designated microscopy center. So one DMC is for 50,000 population, and one TB unit can supervise 2 to 4 DMCs. This can come in your exams, okay? This is expected. This is important. Remember, central TB division, state, district tuberculosis unit, 1 to 2 lakh populations where both treatment, diagnosis and lab supervisors, everything is being done. And then you have TB diagnostic centers, one for every 50,000 population. Okay? That was about TB. It is very, very important. I've given you all the latest updates also, and drug regimens also, and definitions also. Anything can come in your exams. Now let us quickly talk about HIV and NACP. Okay, so HIV में agent, what is the HIV? You all know it's a single stranded RNA virus, belongs to lentivirus family. There are two types, HIV 1 and 2, but more common is HIV 1, and this is how you can identify the HIV virus. Okay, this in detail you'll study in microbiology, but still GP41, GP120, this is the image. Now, from PSM point of view, the most important thing was that which is the most common mode of transmission. So please remember, most common mode of transmission, okay, is sexual. All right, this is the most common mode of transmission. Okay, the prevalence, okay, this here you can write most common mode of transmission, everybody, is sexual. But which is the efficiency of this route? It is only 0.0001 to 1%. That means it's the least efficient. Efficiency means the risk of transmission. The risk of transmission is maximum with blood transfusion, like you can see over here. But the burden or route of transmission, like how many cases does it contribute? The burden is only 1%. Okay, so this is very important. Plus, remember one more thing, vertical transmission. Mother to child transmission contributes 5% of total cases, but the risk of transmission is 25% in developed countries and 30% in developing countries. So if somebody asks you most efficient route of transmission, that is blood transfusion. Okay, blood transfusion carries the maximum risk of transmission, everybody. It has the maximum risk of transmission. But what is the most common route of transmission? Of course, it is sexual, and in that also it is heterosexual, because homosexuality data is lacking. Okay? So these are two very important points that you have to know. So therefore, look at the question. Most common mode is sexual transmission. Okay, don't say blood. Blood is the most efficient route. See, maximum efficiency. Maximum efficiency means with maximum risk of transmission, guys. So with maximum risk of transmission, it is transfusion of blood and blood products. All right, age group for AIDS cases in India, 30 to 44 years. Okay, you have to remember 30 to 44 years is the highly afflicted age group. Okay, then epidemiological pattern. Now you have to remember, for HIV AIDS, there is a high risk group. Okay, there is a bridge population, and then the infection is reaching to the general population. So who are the high risk groups? The epidemic starts from commercial sex workers, homosexual, drug users. They are the high risk groups. Okay, and then through them it goes to the bridge population, like clients of sex workers, STD patients. Please remember, if anybody has STD, risk of HIV in them increases 10 times. Risk of HIV increases 10 times in them. Okay, migrant population, partners of drug users, they are all bridge population. From them, here we have next general population. Now, how do I find out what is the prevalence of HIV in general population? Can I go and ask them about their sexual practices or whether they are injecting drugs or no? No. All right. So in this case, to find out the prevalence of HIV among general population, we are using antenatal mothers as proxy indicators. Okay, so what is the prevalence of HIV among antenatal mothers? That is used as a proxy indicator to estimate the prevalence of HIV in general population. This type of epidemic is also known as concentrated epidemic, guys. Okay, this is important. All right, next, see. Now, for these high-risk groups under the program, there is a special term which comes in your exams also, TIs, targeted interventions. So, what is targeted interventions? These are specific group of interventions which are directed, okay, towards high-risk groups. Okay, please remember this. This can come in your exams, towards high-risk groups. Okay, so if a question comes like commercial sex worker, migrant laborers, street children, industrial workers are not at high-risk group. Okay, they are not having unsafe sexual practices for that matter. Even if I ask you doctors, are doctors or healthcare professionals high-risk group? If I ask you whether doctors or healthcare workers, are they high-risk group? No, they are not high risk. Okay, they are not high risk. They suffer from accidental injury. Okay, they suffer from accidental injury. Remember that, in which they have to take post-exposure prophylaxis. So TIs are just specific group of interventions which are directed towards the high-risk group. Okay, and what could be the TIs, guys? TIs could be, please remember, like provision of female condoms. Okay, provision of female condoms. To whom? Provision of female condoms to commercial sex workers. This is being given under NACP program. Okay, not under family welfare program. Okay, only under NACP. Or opioid substitution therapy. Okay, what is it? Opioid substitution therapy. All right. So these are what? These are the TIs. Okay. Now, most common opportunistic infection among people living with HIV in India, we all know TB. And what is the second most common? The second most common is Candida. All right. Most common opportunistic infection among people living in the world. So, pneumocystis candi pneumonia. We can also say Girovesi pneumonia. Okay. All right. Now, let us look at some of the points under the program also. So, when you talk about National AIDS Control Program, this could be like written as one of the options, that when was the first case of HIV AIDS in India? In 1986. And this program was launched in 1987. What is this NACO? NACO, please remember, is National AIDS Control Organization. Okay, what is this? National AIDS Control Organization. Now, NACO ka headquarter is in New Delhi. Okay, and this was the organization which launched NACP. Okay. So again, like TB, under TB program, we have a national strategic plan for TB elimination. Similarly, here we have a national strategic plan for HIV AIDS elimination. This is for 2017 to 2024. Like I said, India wants to eliminate HIV by 2024. And in 2021, all the programs, whether it's communicable diseases, non-communicable diseases, everything has been merged under NHM. Okay. All right. Now, under this strategic plan also, we want to reduce 80% new infections by 2024. 95% of estimated people living with HIV should know their status, and 95% should have ART retention. And again, 95% who are put on ART should undergo viral suppression. Okay. So now, if you remember from the main lectures also, there's a concept of 95, 95, 95, one more 95 to be achieved by 2024. This concept was actually initially 90. This was given by UNAIDS, right? To be achieved by 2020, where we said that 90% of people living with HIV should know their status. 90% of those who know their status should receive ART, and 90% of those who are receiving ART should undergo viral suppression. And the last 90 ensures what? Quality of life. Similarly, this concept was then improvised and made to 95 to be achieved till 2024. This last 95 ensures quality of life. Okay, and India has also now adopted this. India adopted this concept of 95. Okay, 95% of people living with HIV should know their status. 95% should undergo or should be put on ART, and 95% those who are put should undergo viral suppression. Okay. Strategies, again here we have prevent, test and treat. For TB it was detect, treat, prevent and build. Okay, this was for TB. But for HIV, we have what? Prevent, test and treat. Okay? First, we need to prevent. We need to cater the high-risk behaviors. What is the current prevalence of HIV as per the update? Please remember, it is 0.21%. So, it is actually among antenatal mothers, which we have used as a proxy indicator for HIV burden in the community. 55% of HIV positive on patients on ART have a low viral load. Target is to achieve at least 86% of HIV positive patients on ART to have a low viral load by 2026. This is according to one of the latest update points. But again, diagnosis is being done at ICTC centers, integrated counseling, and this is nothing but integrated counseling and testing centers. So, of course, a question will come, what is the screening modality? So, we all know it is triple test, ERS battery. This is ELISA, rapid test and spot test. But diagnostic test is Western blot, RT-PCR. P24 viral antigen detection test is done during which period, everybody? Window period. Quantiplex PCR HIV-1 can be done for adults. Now look over here, children less than 1 year, HIV, DNA, RT-PCR. All this I have summed it up and written which modality you'll use where. Okay, so if we have infants up to 1 year, we are going to use a HIV, DNA, RT-PCR. Best test, the investigation for assessment of response to treatment and effect of ART therapy, whether it's functioning well or not, okay, whether ART is helping or not, is viral load estimation using RT-PCR test, okay. But the reliable test to assess the response to treatment and progression of disease is CD4 count. Please remember that. Okay, like a person is put on treatment. So what is the best test to assess response to treatment? Viral load estimation using RT-PCR. But which is one of the most reliable tests to assess response to treatment? CD4 count. Okay? Screening test, ERS battery, diagnostic test, Western blot. Okay? Also we can have RT-PCR which can be done. Okay? In children, we do up to 1 year HIV, DNA, RT-PCR. That is important. Best test to assess response to treatment is viral load estimation, and the most reliable test is CD4 count. Okay. Then over here, I want to tell you one more thing. For ERS battery, okay, 3 tests are there. When do you do 1 out of the 3 tests? 1 out of the 3 tests is done in case of blood transfusion. But 2 out of the 3 tests is done when a person is HIV positive symptomatic. Yeah, 1 out of the 3 tests in case of blood transfusion. 2 out of 3 tests only when the person is symptomatic, okay? And 3 out of 3 tests means all the 3 tests will be done when the person, everybody is asymptomatic, okay? So 1 out of the 3 tests is done in case of blood transfusion. 2 out of the 3 tests when the person is symptomatic. But all the 3 tests will be done when the person is asymptomatic. Okay? Alright, a few more updates. Under NSAP, we believe in opt-out testing. Okay, opt-out testing. What is it? Now, routine tests, it means that HIV test is routinely offered. Okay, and the consent is assumed unless, of course, the person denies it. Like, see, there are 2 things, opt-in and opt-out. Like, if somebody feels that he has risk factors for HIV and wants to get himself tested, that is opt-in. Okay, so testing is offered and the patient is required to actively give permission before it can occur. This is opt-in. But second one, dekho, means performing an HIV test after notifying the patient that the test is normally performed, but that the patient may elect to decline or defer testing. Assent is then assumed unless, of course, the patient declines testing. This is opt-out. So, for pregnant females under WHO or CDC, we prefer opt-out testing. The pregnant female is offered those routine tests that you will be doing. We will be getting your hemoglobin, RH, VDRL, HIV, HbS, AG done. The pregnant female says, okay, doctor, do it. Okay. So, we assume her consent unless, of course, she opts out. Okay. That is important. Okay. Next, let us come to management of HIV. So, the first is treat all initiative. That means any person who is HIV positive will be put on ART irrespective of CD4 count. Okay, earlier it was like that if CD4 count is less than 350, 250, then we will start ART. Now it is under the program, anyone who's HIV positive will be put on ART irrespective of CD4 count. Okay, so treat all is the strategy which is adopted. Every patient to be given ART irrespective of CD4 count. Okay, now what is the treatment modality? We all know that for HIV positives we have fixed dose combination tablets now. Okay, like in TB also we use fixed dose combination tablets. In TB adults के लिए we have 5 weight band categories, and for children we have 6. So now the drug of choice for adults who are HIV positive is not TLE. Earlier it was tenofovir, lamivudine, efavirenz. Now it is tenofovir, lamivudine, dolutegravir. Okay, and for children who are HIV positive, either zidovudine or abacavir plus lamivudine plus dolutegravir. For newborns, we are going to now put them who are HIV positive, zidovudine, lamivudine, and we have added a new drug now, introduced a new drug, raltegravir. Okay, if that is not active, if that is not available, then liponavir or ritonavir. But remember, this is very important for adults who's HIV positive now. The drug of choice is TLD, tenofovir, lamivudine, and dolutegravir. Okay. And for newborns, we have introduced the drug now, raltegravir. This is important. Now, this is what prevention of parent-to-child transmission. This is an image also. This is an image-based question also. We all know mother-to-child transmission contributes 5% of total cases. But what is the efficiency of the route? So efficiency of the route is 25 to 30%. Okay, 25% in developing country, in developed, and 30% in developing. Now, what do you do when a woman is HIV positive? Okay, so HIV positive pregnant females, our drug of choice is now, as per update also, tenofovir, lamivudine, and not efavirenz. Earlier it was, but now it was dolutegravir. ठीक है, irrespective of the trimester, put her on TLD. She will be put on TLD. Then a newborn to a HIV positive mother. If the mother is on ART, we will use nevirapine for 6 weeks. The baby has to be put on nevirapine syrup for 6 weeks. If the mother is not on ART, then he is a high-risk infant. So both nevirapine as well as zidovudine. And cotrimoxazole prophylaxis will be given from 6 weeks till 18 weeks. Okay, 18 months. We are going to confirm the HIV status at 18 months. Okay, and accordingly do the further management. All right. What is prophylaxis which is being done? So you just have to remember, any woman who's HIV positive, pregnant woman, put her on TLD irrespective of the trimester. Baby who's born to HIV positive mother, the woman is on ART, we'll use nevirapine for 6 weeks. But if the mother is not on ART, we'll be putting both nevirapine as well as zidovudine, and this can also be extended up to 12 weeks. Okay? Okay. Now, if in under HIV program, when we have to talk about prophylaxis, one is post-exposure prophylaxis. So this is given during what? Accidental needle prick injury. Although the efficiency of this route is very less. Okay, what is the drug of choice here? Also TLD, started within 72 hours for 28 days. Okay, best if it is started within 2 hours. The sooner the better. And here the person gets earned leaves. Okay, the leaves the person will get which are paid. Now also in case, like you all know, pneumocystis carinii or girovacin is the most common opportunistic infection among people living with HIV. Okay, globally. So to prevent that, if the CD4 count, okay, we have to give double strength cotrimoxazole. It is started when CD4 count is less than 350. Like see, if the person is HIV positive, you put on ART. But for cotrimoxazole, the CD4 count has to be less than 350 to give cotrimoxazole. Stop when CD4 count is more than 350 cells for more than 6 months. Okay, so this is important. For prophylaxis, we have post-exposure prophylaxis in which we are giving TLD. Okay, in accidental needle prick injury, and also to prevent pneumocystis jirovecii infection, double strength cotrimoxazole. But that is started only when CD4 count is less than 350. Now in India, what is the most common opportunistic infection among people living with HIV? TB. So to prevent TB, if in case it has not occurred still, okay, you will put the person on 6 months isoniazid, okay. But if doesn't want to take for so long, we can now put TB preventive therapy में 3 months isoniazid plus rifampicin. And since the person is on isoniazid, most common vitamin deficiency noted is pyridoxine, so you have to add vitamin B6 or pyridoxine with isoniazid. Okay, this is very, very important. And one more thing in HIV you need to know is the sentinel surveillance, okay, which is done to find out the burden of HIV in community. Basically, sentinel surveillance is done to find out the missed cases. It is a form of what? Notification of HIV. And remember one thing, when we do surveillance, okay, sentinel surveillance, basically any form of surveillance is trying to find out, we are trying to learn about what is the incidence or prevalence of disease, okay, the distribution of disease, okay, trend of disease, all those things. So in this HIV sentinel surveillance, it's done, you know, once every 2 years. When we do it once every 2 years, it means it's done biennial. Okay, it is done among high-risk groups also, bridge populations also. Okay, but most important is general population के लिए we are using antenatal mothers as proxy indicators. High risk group में commercial sex workers, transgenders, MSM is men having sex with men, IV drug users. Bridge population like we saw truck drivers and single male migrants. ठीक है, for sample size 400 among ANC females, 250 each for bridge populations and high risk group. ठीक है. So, total sample size, if anybody asks you, please remember we are not doing it now and among STD patients. That is no longer being done. So, total sample size, if anybody asks you, 400, 250 and 250. Okay. So, total sample size is now 900. But among HIV mothers, because we are using that as a proxy indicator, most important becomes HIV mothers. In that, we are doing it among 400 females. Okay? So remember the word sentinel surveillance, it's very, very important. That was about HIV. Okay, right from the diagnosis to the treatment, everything is important in the program of HIV. Okay, so next in the program is NVBTCP. This is National Vector-Borne Disease Control Program. Okay, what is this? This is National Vector-Borne Disease Control Program. Okay, this National Vector-Borne Disease Control Program came in 2002. Okay, earlier we had separate programs like, you know, malaria was running as separate program. Japanese encephalitis, filaria, kala-azar, everything was being running a separate program. Then, since all of them are happening by mosquito and kala-azar like sandfly, but the management is the same. It's integrated vector control. So, they were all clubbed under NVBDCP. Can you see this logo? Okay, there's a ring and there's a mosquito. So, the important question is that in in 1953 we had National Malaria Control Program. Then in 2002 we had Vector-Borne Disease Control Program, when most of the diseases, vector-borne diseases, were brought under this. So the question is, how many diseases are included in NVBDCP? If you look at this, it has 6 letters. Okay, so 6 diseases. Now how can you remember this, everybody? What are the mosquitoes we know of? Anopheles, Aedes, Culex. Okay, so Anopheles is transmitting malaria. Aedes is transmitting dengue, chikungunya. Kala-azar, Japanese encephalitis and filariasis. Okay, and the next thing is not a mosquito but a sandfly. Okay, so sandfly, this transmits what? Kala-azar. Or most important over here, visceral leishmaniasis. So we can see 6 diseases. All right. Now remember, Aedes also transmits yellow fever, but that doesn't happen in India. Zika virus also, but that is no Rift Valley fever also, but they are not part of NVBDCP. Okay, so 6 letters, 6 diseases. Here I want to just revise with you one point for filariasis. What is the species of Culex? It has the F letter in it, Quincke fasciaticus. okay, or Culex fatigans. And for JE it is Culex tritonio-rhynchus या Culex vishnui. ठीक है? Now, National Vector-Borne Disease Control Program target is we want to achieve an API. API is what? Nothing but annual parasite incidence. Okay, annual parasite incidence reflects the burden of malaria. Okay, so we want to reduce the burden of malaria to less than 1 case per 1,000 population. And ABER, what was this ABER which we have studied in diseases? Annual blood examination rate. Okay, an annual blood examination rate is telling us actually about the operational efficiency of the program. Okay, operational efficiency of program. So we want to achieve an ABER of more than 10%. Plus, we want to eliminate Kala Azar and lymphatic filariasis as soon as possible. We've been trying to do it since 2015. Okay, and control mortality and morbidity from dengue. Here, please remember, elimination criteria of Kala Azar is the same as leprosy, less than 1 case per 10,000 population. And for lymphatic filariasis, it is prevalence or microfilary carrier rate to less than 1%. Okay, so these are the targets that we have to achieve under the program. So for that we have integrated vector control measures. This is the most important. Yahan pe we have anti-larval, anti-adult, against mosquito, personal protective measures and legislative measures. Now when I talk about anti-larval, I hope you remember ECB, environmental control. Environmental control, everybody, was source reduction. That means this is yield. Source reduction yields what? Source reduction yields, everybody, yields permanent result. Okay, so environmental control. Chemical control, we are using anti-larval measures, and biological control, we are using biological methods. Okay, I'll just show you. Anti-adult mein we have space sprays, indoor residual sprays, and genetic control. Against mosquito, mosquito nets, screening, repellents. Okay, so most important, see, anti-larval. Environmental mein we are doing source reduction, which yields permanent methods. We don't want the larva only to breed. Okay, so for that, like we all know that Culex breeds in dirty water. Fill up all the dirty drains. Okay, so minor engineering methods, filling, leveling of ground, drainage of breeding places, and water management. So you render water unsuitable for mosquito breeding. So you would be asked, which is the method, integrated vector control method, which can yield permanent measure results? It is anti-larval mein environmental measure or source reduction. Chemical control mein, very, very important, we use anti-larval chemicals. Paris green was used earlier, but now we also prefer abate. Okay, please remember, abate is one of the preferred ones. Biological control mein we are using larvivorous fishes like Gambusia affinis and Libester reticulate. So they eat the larva. Okay, that is very important. They can be used in burrow pits, sewage oxidation ponds, ornamental ponds, wherever. Then important is anti-adult measure. In anti-adult measure, we have to do a space spray, guys, or we do indoor residual spray. Okay. Now, where would you do a space spray? Okay, where would you do indoor residual spray? So that depends on the API level. If API level is less than 2 for any area, so whenever a case of falciparum happens, okay, then we will do a space spray. But if the area has API more than 2, okay, then we do indoor residual spray depending on the chemical that we are using, DDT or malathion or pyrethroids. It could be 2 rounds or 3 rounds at intervals of 6 weeks during transmission season. Abhi aap dekhoge. See, space spray mein we are using malathion. Residual spray was being done with DDT, but now resistance has been seen, so we can use malathion also, pyrethroids also. But to know where to do space spray and where to do indoor residual spray, we have classified the states and districts based on API category. Okay, so this classification is done on API. Like there are category 0 states where we have to prevent re-establishment phase. Koi bhi state is 0 mein nahi hai. Okay, koi bhi state category 0 mein nahi hai. Okay. Okay, re-establishment means that no cases of malaria is occurring, 0 indigenous cases. What is category 1? Elimination phase. That means API of less than 1 case per 1,000 population has been achieved. Okay, category 2 is just prior to elimination. Most of the districts in the state have API less than 1 case per 1,000 population, but some districts still have API 1 per 1,000 or above. Intensified control phases where the API of 1 case per 1,000 population or above. So depending on whichever category the person is falling, the state is falling in, we are going to take up the measures. So like you can see, areas with API more than 2, less than 2. Less than 2 may we will simply do a focal spray of DDT or malathion or BHC whenever a case of Plasmodium falciparum occurs. But when the area is API more than 2, residual insecticide spray has to be done at 6 weeks intervals. Okay, now here again it depends. You can start with 2 rounds of DDT in transmission season, 1 gram per meter square. But if the vector is refractory to DDT, we will do 3 rounds of malathion, which is 2 gram per meter square. This is being done in transmission season. If the vector is refractory to both DDT and malathion, we are going to use what? 2 rounds of pyrethroids at 6 weeks interval. Okay? Now, if the area is 2 to 5 more, or if the area, see, API less than 2, more than 2, less than 2, focal space spray. Okay, more than 2, indoor residual spray. Depending, DDT 2 rounds, malathion 3 rounds, pyrethroids again 2 rounds at 6 weeks interval. Here you will further divide it into 2 to 5, more than 5. So if it is 2 to 5 everybody, we can use conventional nets also. Conventional nets. If it is more than 5, we will use LLIN, long lasting insecticide treated nets. See, areas with API more than equal to 5 to be covered with LLIN. Long lasting, okay, this is important, long lasting insecticide treated nets, and areas with API between 2 to 5 have to be covered with conventional nets. Okay? Alright, so this is important. Okay, how we are doing integrated vector management. For diagnosis of malaria, thick and thin smear are prepared. Thick smear using JSB stain, okay, just one Bhattacharya stain, okay, that is important, or GIMSA also. Thick slide is to identify parasites, so this is hinting on the sensitivity, thick slide, and thin slide tells us the species, so this is hinting on specificity. Okay, again important. Treatment, we all know, what have I taught you? Walk. If it is Vivax ovale, we are using which drug? Chloroquine. Pregnant, non-pregnant, whatever. So Vivax में chloroquine for 3 days, plus we have to add primerquine for 14 days. Okay, in pregnancy, however, primerquine will not be given. Falciparum, what was it? ACT, artemisinin combination therapy for 3 days, plus primerquine single dose on 2nd day. Okay, so here in northeastern states, guys, it is ACT-LM. Artemether lumefantrine. In other states, it is ACT sulfadoxine pyrimethamine. ACT SP. Okay? So please remember, when it is falciparum, we have to go for ACT therapy. ACT combination, artemisinin combination therapy for 3 days, but primerquine has to be given on 2 days. If the person resides in other states, it is ACT SP, and if the person resides in northeastern states, it is ACT LM. LM is artemether lumefantrine. Alright, this is very, very important. Please don't forget it. It can come in your exam. Now here I have written chloroquine ka dose for Vivax, guys, 25 milligram per kg body weight over 3 days. Primerquine for Vivax, when we are adding for 14 days, it is 0.25, and for falciparum, when it is added on day 2, it is 0.75. Artesunate 4, sulfadoxine 25, pyrimethamine 1.25. Sometimes they ask you the dose as well. But in pregnancy, for Vivax, walk, chloroquine, primerquine not given. For falciparum, first trimester, quinine salts are given, but for 2nd and 3rd trimester, ACT. If again it is other states, ACT SP for 3 days, and otherwise northeastern states, ACT LM. Please remember here ACT में in pregnancy primer queen is contraindicated. ठीक है? This is important. Mixed infection area specific ACT plus primer queen for 14 days. Prophylaxis for malaria if the travel is for more than 6 weeks. Long term the choice is mefloquine. Short term the choice is doxy. How can you remember? Now the distance from A to D is less. So short term, doxy, 1 to 2 days before travel and continue for 4 weeks post travel. But distance from A to M, guys, is longer. So what are we using? Mefloquine, 2 to 3 weeks before travel and continue 4 weeks post travel. Okay, this is very, very important. Prophylaxis, short term, doxy, long term, mefloquine. Personal protection, we can use mosquito nets, which is insecticide treated nets. So the chemicals which are being used is pyrethroids. Maybe they can ask you, of course, they actually ask you conventional nets, okay, which we are using when API is conventional nets. When is this being used? When API is between 2 to 5, okay, 6 to 12 months. Retreat it every 6 months. Long lasting nets are used. They have a shelf life for more than 3 years. Here, when the API is more than 5, they can be used. This is a PYQ. Number of holes per square inch is more than 150 and diameter of each hole, everybody, is less than 0.0475 inches. Okay? Alright, so that was about malaria. That was about vector-borne disease control program. Everything is important here. The logo, diseases included, diagnostic modalities, integrated vector control measures, anti-larval, anti-adult. When are you doing indoor residual spray? When are you doing focal spray? Okay, anti-larval is the best method, source reduction. What about the treatment? So Vivax, Ovale, chloroquine. But if it is falciparum, ACT, ACT, SP in other states, ACT, LM in northeastern states. In pregnancy also you can give, but first trimester in pregnancy in falciparum is quinine. Prophylaxis, short term travel, so doxy, long term meflo. Okay, let's come to leprosy now. Currently the prevalence of leprosy is 0.45 per 10,000 population. Do we say leprosy has been eliminated? Yes, of course. India eliminated leprosy back in 2005 only. India eliminated leprosy, and then the elimination criteria was less than 1 case per 10,000 population. Okay, so this has already been achieved. Grade 2 disability rate, if you can see, 1.36 per million, but new case detection rate is now 5.52. Okay, all right, maybe they can ask you, but more important is the elimination criteria for leprosy. This is the logo, this is the symbol of lotus. Lotus stands for hope. Okay, it's the oldest disease known to mankind. Now when you have to do diagnosis of leprosy, you all know it is based on clinical grounds, paucibacillary, multibacillary. Now what is paucibacillary? In this, the skin lesions, everybody, could be less than equal to 5, but in multibacillary it is more than equal to 6. Nerve involvement in paucibacillary, no nerve could be involved or only one nerve involved. In multibacillary, we have how many nerves involved? 2 or more nerves involved. Plus paucibacillary, we might not get any positive skin smear. Any skin smear could come positive. Okay, so this is very important. Based on skin lesions, pauci is less than equal to 5. Multi is more than equal to 6. And of course, based on nerve involvement. Other than that, bacillary index less than 2, more than 2. Okay, 2 and above. Okay. Then the important thing that I want to stress over here is that now for treatment we are using all the 3 drugs: rifampicin, dapsone, clofazimine. Okay, treatment duration in paucibacillary is 6 months, which can be completed up to 6 to 9 months. 12 months is for multibacillary, 12 to 18 months. Okay, and follow up after treatment is a PYQ annually for 2 years. It is done in case of paucibacillary, and multibacillary it's done annually for 5 years. Okay, so please remember, this is important. Now this is the WHO schedule, okay, where we are using 3 drugs for treatment of leprosy. Okay, rifampicin, clofazimine, dapsone. Paucibacillary 6 months, multibacillary 12 months. Okay, for children also, and for children less than 10 years old or less than 40 kgs also. You can go through the doses also. Now certain initiatives which have been taken. So this is who, this girl is who? She is what is known as Sapna. Okay, so Sapna is a village girl. It's a mode of primary prevention. Okay, she's a village girl who's spreading awareness about leprosy. Okay, and this concept was adopted from MENA. Okay, MENA was a concept launched by UNICEF, which was dealing with child rights and empowerment. Okay, and it was very, very successful, and that concept was adopted by Leprosy Trust Mission India to have this sapna. ठीक है, plus you are asked Sparsh program. This is to create awareness about leprosy only using the mascot Sapna. Sapna, I told you, is a village girl spreading awareness. Okay, plus under this primary strategy, we are also talking about giving profile access to close contacts. See, up to 10 to 13% of close contacts will go on to develop leprosy within 5 years. So what is the drug of choice? Profile access given to close contacts, household contacts, social contacts is single dose rifampicin. This is very important, guys. Do we get profile access for leprosy? Yes. Which drug do we use? Rifampicin. Okay, because all the close contacts can develop up to 10 to 13% of them leprosy within 5 years. So which drug we are using? Rifampicin. Okay, then for monitoring and evaluation of the program, this is an upcoming question. Monitoring and evaluation of the program, we have some core indicators like ANCDR. ANCDR is annual new case detection rate. Okay, this is an epidemiological indicator. If it becomes more than 10 per 1 lakh in high burden areas. Grade 2 disability indicator per 10 lakh population, we are also taking. Cure rate is being taken, like this is an operational early case detection indicator, grade 2 disability. Plus we are also taking epidemiological indicators like what is the cure rate and long-term impact में prevalence rate. Here I just want you to remember one thing, this is important. That prevalence rate has to be kept below 1 per 10,000 population. We all know at district subnational level. Grade 2 disability rate should be to reduce grade 2 disability percentage to less than 1 among new case at national level. New cases should suffer from less than 1% disability rate. To reduce disability, grade 2 disability cases to less than 1 case per million. Okay, so just a summary of this. Most important epidemiological indicator is ANCDR. Most important operational indicator, grade 2 disability, and you know its percentage should be less than 1 among new cases. Okay, less than 1 case per million, that is important. And most important health awareness or leprosy awareness indicator is grade 2 disability indicator. This is one of the important slide. Which is the most important epidemiological indicator, which is the most important operational indicator for leprosy, and which is the most important health awareness or leprosy awareness indicator. Now there's a new initiative which has come up, Leprosy Mukt Bharat, to be achieved by 2027. Okay, 3 years ahead of SDG. We are focusing again on early detection, secondary level of prevention. Please remember in this, if ASHA detects a case of leprosy, okay, without disability, she gets an incentive of rupees 250. And if she is able to detect a case of leprosy with disability, she is getting how much? Rupees 200. Okay, so the program is still focusing on early detection, free of cost treatment to prevent development of disabilities and deformities. And you know the importance of grade 2 disabilities, medical rehabilitation of those with existing deformities. And to improve reconstructive surgeries, we have also giving an allowance, welfare allowance raise up to 12,000. Okay, this is very, very important. Please remember, this can come in your exams. Okay, that was about leprosy. I think the most important thing from leprosy which can come is the treatment, the profile access using rifampicin, the classification of course, and also the Sapna mascot. Okay, last but not the least, just a quick look at polio. Now we all know that the world wants to eradicate polio till 2023. So there's a polio endgame eradication strategy, guys, till 2023. Okay, now polio is still endemic in Afghanistan and Pakistan. And which is the strain which is still present? Wild polio virus type 1. We all know wild polio virus type 2 got eradicated when? September 2015, while poliovirus type 3 got eradicated in October 2019. So the one still present, while poliovirus type 1 still circulating, where Afghanistan and Pakistan. Okay. So we wanted to end, the world wants to end polio now, eradicate. India currently is polio free. Okay, India currently is polio free. The goal of switch was made from trivalent OPV to bivalent OPV. Okay, from this 1, 2, 3, we switched to 1 and 3. 2 component was removed. Why? Because while poliovirus type 2, okay, this was associated with CVDPV, circulatory vaccine derived poliovirus, which could circulate and lead to outbreaks also. Okay, this was very dangerous. But it was eradicated in September 2015. So it was thought, why to still retain it in OPV? So we switched from trivalent OPV to bivalent OPV. Any routine immunization round or supplementary immunization round, we only use bivalent OPV now. Okay. Some facts. Last case of polio in India was Jan 2011, West Bengal. India was declared polio free. 3 years later, 27th March 2014. Now, sequential pulling back of OPV and start of IPV is called polio endgame eradication strategy. Ultimately, OPV should be replaced with IPV. Okay. Because IPV is not associated with any vaccine-associated paralysis. No. Okay. So, ultimately, we want to replace OPV with IPV. Remember, IPV was introduced, IPV is the killed form, it was introduced prior to switch. Okay? That is again important. So this is it. Withdraw bivalent OPV and routine OPV use, and ultimately it was we have to replace OPV with IPV. This was to be achieved till 2020. नहीं हुआ है अभी तक. We are targeting at it. And polio endgame eradication strategy means to replace OPV with IPV eventually. Goal 1 is eradication. Goal 2 is integration. And once eradication has been achieved or elimination has been achieved, that has to be maintained. So we cannot weaken the polio surveillance, okay, which you will just see. And last is certification and containment. National polio surveillance program is the responsibility of surveillance medical officer or district immunization officer. They have to be an MBBS. It cannot be done by a health worker. Okay? Now, we all know AFP cases, acute flaccid paralysis. Okay, so this polio surveillance is being done among which age group? That is very, very important. Okay, so this is being done among 0 to 15 years. Okay, so AFP is a clinical syndrome which refers to a collection of signs and symptoms instead of a diagnosis. It is defined by the acute onset of weakness or paralysis with reduced muscle tone in children. Any case of AFP, if it is reported, okay, should be put under investigation within 48 hours. Now, it's not necessary that this flaccid paralysis is polio. It could be anything else also. It could be transverse myelitis, GBS also, Guillain-Barré syndrome. But we need to do an investigation as soon as it is reported, okay? So, AFP surveillance is active case finding and passive reporting of AFP in children 0 to 15 years. It will only be done by a medical, by an MBBS doctor. So, start investigation. These are all PYQs. Start investigation within 48 hours of reporting of an AFP case, okay? First stool sample is collected within 48 hours and the second stool sample is collected 24 hours apart, ideally within 14 days of onset of paralysis, okay? Like as soon as a case of AFP is reported, the first stool sample should be collected within 48 hours. Second, 24 hours. But all this thing, okay, should be done within 14 days of onset of paralysis. Then they are transported to NIV. NIV is National Institute of Virology. Okay, National Institute of Virology. Where is it? National Institute of Virology in Pune. In reverse cold chain. Reverse cold chain, you remember, red carriers. Why? Because the temperature needed to carry the stool sample is also +2 to +8 as for vaccine vials. We will check for residual paralysis on 60th day only and we can confirm a case of polio within 90 days. Okay, this is the entire process which you have to remember. And what is the stool size? Is 8 grams, okay, which is roughly the size of a thumb. Okay, all this come in your exams. In case while poliovirus detector mop-up rounds are conducted, confirmed cases, isolated poliovirus in stool, and or it can be a compatible case, death within 60 days of paralysis, or only one stool sample available with residual paralysis on 60th day. Okay. Now the point to be noted is that every AFP case need not be polio, guys. Okay. So how do we know that our surveillance is being conducted in a well-organized manner? Whenever we survey children below 15 years, okay, up to in a population of 1 lakh, we need to find at least more than one case of AFP. Okay, so this is monitoring and evaluation indicator, which is a AFP reporting rate, okay, which says that it should be more than one AFP case per 1 lakh per year in all children less than 15 years of age, sensitive indicator for ability to detect polio in community. It simply means that when we survey a population of 1 lakh, okay, 0 to 15 years, we must find at least more than one AFP case per 1 lakh population every year. Okay, that could be not necessarily polio, it could be anything else also. Okay, plus stool adequacy rate should be more than 80%, indicator for operational efficiency of the program, that whether program is running efficiently or not. For that we have stool adequacy rate, which should be more than 80%. The stool sample should reach the lab within 72 hours of collection. Mopping up, if they say, where do you do it in case of polio? So it is an end-stage strategy used when poliovirus transmission has been reduced to a few foci. So when we see that poliovirus transmission in a country has been reduced to a few foci only, or to a few countries only, we do mop-up rounds, which involves additional door-to-door immunization. Minimum 2 rounds, 4 to 6 weeks apart. In India, it was done 3 rounds. So all I wanted to tell you is that mopping up is done for polio. Each mopping up, we need to cover 2 to 5 million under 5 children. Okay. Line listing is also a term associated with polio. Okay. Line listing of cases is done so that we avoid duplication of cases. All right. We don't screen the children again who've already been screened, or identify high risk pockets. Okay. That was about polio. Polio mein national polio surveillance program is very important, guys. What is the procedure, how it is done? Okay. That you must know. Last thing, this is National Program for Control of Blindness and Visual Impairment. Now, according to program, what is the definition of blindness? Visual acuity less than 3/60 in better eye with available correction. Please don't say best possible correction. Okay. And what is visual impairment? Visual acuity less than 6/18 in better eye with available correction. Obviously, you will be asked what is the causes of blindness and all that. So major cause of blindness, everybody among more than 50 years, is cataract, less than 50 corneal opacity. Visual impairment, again cataract, then refractory errors. 0 to 49 years, refractory errors. But if anybody asks you overall, most important cause of blindness and visual impairment, cataract. Okay. And according to the latest update, the program currently provides primary and secondary eye care services within NHM. Okay. Cost sharing between center and state maybe can come. Okay. Center is sharing 60%, 40%, and Northeastern it is 90-10. Just look at this one point, that we want to reduce prevalence of blindness to 0.25. If you see, currently it is 0.365. But we want to reduce it to 0.25, okay, with a proposed total of 270 lakh surgeries to be carried out over the next 3 years. 270 lakhs, okay, surgeries. Now, we all know that cataract is an avoidable cause of blindness. Okay, it's a treatable avoidable cause, which is also being covered under Vision 2020. Okay, so this was it about some of the programs. Okay, I've tried to cover it, almost all the important points from all the important programs. To go through it once, this will really help you in your exams. Thank you so much.